I'm Dr. Garcia. This is my technique for a minimally invasive lapidus utilizing a tripod screw fixation technique and a percutaneous approach. So first things first, before we get going, a note on patient positioning. With this procedure, it's very important that the patient is in a maximally elevated position with the knee bent so that your foot is in line with the weight-bearing surface of the X-ray of the detector. It's going to help standardize your view for the rest of this procedure. So the closest you can get to benchtop, the better. First things first, we're going to go ahead and grab a lateral, and we're going to identify the longitudinal axis of the first metatarsal. Perfect. With our longitudinal axis identified, we're going to trace that out. Next, we're going to identify the first met cuneiform joint space. And we'll make a small mark here. We'll also circle our portal of entry, at which point we're going to switch to an AP. From this view, we're going to identify first the base of the first metatarsal. Which we will identify. We'll then outline the articular facet of the medial cuneiform. And then lastly, our angular correction that's going to help reduce our IM. So 3 discernible lines, A, B, and C. At this point, I'll take my 15 blade. I'm going to identify our portal of entry, which we already marked. I'm going to incise down to periosteum. This time, I'm going to take our curved elevator, and I'm going to create a pocket, a soft tissue pocket to work in, basically tracing the shape of the medial cuneiform dorsally and plantarly, and that's going to accomplish 2 things. It's going to create some working space for our burr work, as well as visualize the height of the medial cuneiform that needs to be prepped. We'll take a shot. Perfect. So that is the dorsal surface. Go ahead and elevate the plantar surface. Perfect. Excellent. So with our soft tissues elevated, we can then move towards our joint prep. An important note about our joint prep, because this is percutaneous and we're trying to keep this preparation consistent and reproducible, we're going to utilize a quadrant technique for preparation. So I'm going to identify the base of the first metatarsal, the dorsal surface. This is quadrant 1. I'm going to identify the base of the first metatarsal planarly. That's quadrant 2. The dorsal surface of the medial cuneiform joint would be quadrant 3, and the plantar aspect of the medial cuneiform joint would be quadrant 4. So at this time, we're going to load up our burr. We're using a 2.2 by 20 recta burr. Prior to joint preparation, one guiding principle that I always adhere to is the line of travel should be opposite the rotation of the burr. So if we're traveling right, our burr is then going to be rotating counterclockwise. And this achieves 2 things. It prevents skirting of the burr and helps improve control. It also, again, digests this joint preparation into small segments, which increases reproducibility and consistency. At this point, we're going to do our dorsal prep of the first met base. And the reason we're using the recta burr is this is just denuding cartilage. We're not trying to achieve any angular correction. So we'll get a shot to ensure placement is within the first met cuneiform joint. Perfect. Perfect. So with the burr in a kind of a parallel alignment with the weight-bearing surface, I'm not going to drop my hand. I'm going to use a steady sawing motion back and forth, like a pistoning motion, as I work my way from the center of the metatarsal cuneiform joint to the dorsal surface. And you'll start to hear, I know this is a cadaver, but you'll start to hear a high-pitched whine when you broach that subchondral bone. And that's your cue that you're starting to denude cartilage and reach that subchondral bone. So we'll do a couple more passes here in this first quadrant. I'm going to take an X-ray shot and ensure that I'm against the base of the first mat. There we go. Okay, now at this point, I'm going to switch the burr rotation to counterclockwise as I do quadrant 2, which would be opposite the direction of travel. All right, we'll get a shot before we move to the medial cuneiform. Cool. So at this point, we're going to move forward with the medial cuneiform articular surface joint prep. With this, you can do one of two things. You can either prep the articular surface to denude the cartilage and then perform your angular osteotomy, or you can do it all in one motion. It's up to the surgeon entirely. So, but I am going to make sure that as I go into quadrant 3, because I'm moving the burr dorsally, I want to make sure that I am counterclockwise, which we are in. So get an X-ray shot to ensure that we're against the articular surface of the medial cuneiform. Perfect. Okay, at this point, we're going to go ahead and do our fourth and final quadrant, the base of the medial cuneiform articular surface. So we will switch this then back into a clockwise rotation pattern. Good. So at this point, I've denuded cartilage off of the base of the first metatarsal and the articular surface of the medial cuneiform. We're going to get another shot. And at this point, prior to your angular correction, you can insert a 2.0 or 2.7 small joint arthroscope and visualize your joint preparation to ensure there is no remaining cartilage and that the subchondral bone has been broached. And at this time, if there's any fenestration work that needs to be accomplished, we can do so with the burr, and we can accomplish that by dropping our hand in this fashion. Get a shot. And then by running the burr, you can broach the base of the first mat. You can reorient your burr and then do the same to the medial cuneiform. Get a shot. Perfect. So I'm going to go ahead and distract the first mat. So at this point, we're going to re-enter the first metatarsal cuneiform joint at center, which we've already marked. And then we're going to use our C line, which is our angular line for angular correction that we previously marked out as a reference point as we create that angular correction in the face of the medial cuneiform. So go back and do my fourth quadrant, switch the orientation. So it's still important when you do your resection that you're adhering to those rotation principles. So if you're prepping the dorsal surface of the medial cuneiform, you're in a counterclockwise pattern. And if it's the planar surface, you're in a clockwise pattern. So at this point, we're prepping that dorsal surface of the medial cuneiform, so we should be in a counterclockwise pattern. Perfect. We'll go ahead and do some passes on the planar aspect. With care taken to switch, again, the rotation of our burr to back to clockwise. All right, so let's go ahead and put a little bit of distraction on the joint, see how our preparation looks. So there's the planar surface. Needs a little bit more work on that planar shelf. So let's move back to our dorsal cut, which is counterclockwise. Perfect. All right, so we can see we've imparted some angular correction at the face of the medial cuneiform. We're ready to assemble our Bun-Yo-Matic clamp to aid in reduction. Prior to reduction with the Bun-Yo-Matic clamp, this would be the time to backfill your joint preparation site with the biologic of your choice, or if you choose to harvest bone marrow aspirate, bone marrow concentrate, injecting through your portal of entry with an angiocath tip can be useful in doing so. So using our J-arm off the Bun-Yo-Matic clamp, we're going to go ahead and site the second metatarsal head. So with our lateral arm placed over the second metatarsal head, we're going to go ahead and place our provisional wires for fixation. All right, and now we can feed on the lateral portion of the clamp. Perfect. Check our position. Excellent. Let's bring a little bit more of the first met cuneiform into view. Cool. At this point, we're going to compress the jig so the plunger is in contact with the medial aspect of the first met. Okay. Perfect. Go ahead and throw our wire. We're going to ensure when we place the wire that we're bicortical in the first metatarsal head. Almost there. Perfect. At this point, we're going to place our wire sleeve through the nail eyelet. And then we'll grab a shot. Perfect. At this point, we'll grab a lateral image to ensure placement on the medial cuneiform. Good. Awesome. So then we will load our wire up for our medial cuneiform fixation. Perfect. A little bit more. Good. All right. So when you're happy with your axial compression, we're going to go ahead and impart translocation. So with our black knob, we're going to begin to compress. Yeah, I really like that. Okay. And now it's time to derotate. So from neutral, we're going to take this to 10 degrees. And we'll get a shot. And I can start to see a little bit of that fibular sesamoid become covered. At this point, we're going to throw our wire for our anterior to posterior wire throw. A good indicator, or good point of reference would be the weight-bearing surface. You want this wire to be parallel to the weight-bearing surface right up until you enter the skin at the metaphyseal, diaphyseal junction of the first met. So we'll go ahead and get a shot. It's probably pretty good. So with my hand still parallel to the weight-bearing surface, I'm going to raise my angle of attack to match the met declination. Perfect. And then we will make our throw. And I'm not hitting my pin, which is good. And then we can check on a lateral. Okay. So now, probably advance that ever so slightly so I can feel that plantar cortex. Good. And this wire throw, your goal is to be perpendicular with your initial wire throw. So coming in. Perfect. Perfect. So if you can see there through the post where our medial cuneiform fixation is, we need to advance our wire slightly. So we are exiting the plantar cortex of the first mat. All right. So I got a 15 blade up. I'm going to go ahead and make an incision where my anterior to posterior wire is going. I'm also going to make an incision where my posterior to anterior wire is traveling. All right. Trade you for the depth gauge. So right up there. Right at the bone, 46. We'll take 2 off. We'll do 44. Anterior to posterior, and then posterior to anterior. That is a 38. So we'll get a shot. Sure, right on the cortex. I'm going to fall through that cortex. Get another shot. Excellent. And then I can feel that plantar cortex of the medial cuneiform. We're about to broach. Perfect. And then since we have our reduction, we can drill the other wire at this time. Go ahead and trade you for the anterior to posterior screw. Thank you. We'll line up the laser line of the driver, the screw. So leave that proud. Let's go ahead and do our opposing posterior to anterior throw. And then we can disassemble our jig. Let's back that up a little bit. All right, now we have enough provisional fixation. We can disassemble the jig, pull our wires. That looks swell. Let's see if we can do that. Perfect. All right, let's get a lateral. We have our 2 crossing screws to maintain reduction. This is our home run or guarantee screw using one of the headless compression screws. And this throw goes from the base of the first metatarsal into the intermediate cuneiform joint. There we go. All right, I'll take that. Cool. And then, you do kind of have to drop your hand because you're kind of pointing towards the, apex of the arch of the midfoot. So should be good. Yeah, I like that. Cool. Trade you for a 15 blade. So we'll make our incision. $36. Let's do 36. So with our wire thrown for our home run screw, we'll go ahead and drill. So I'm going to broach that cortex. We'll take a shot. I'm going to ensure that I'm not hitting hardware. Perfect. At this point, we're throwing our compression screw across first met into the intermediate cuneiform. All right, that's good. So pearls for this procedure, number 1, patient positioning. You want to make sure that you can resemble a weight-bearing surface as closely as possible. So the best way to do that, patient maximally elevated, supine with the knee bent. Mini C-arm is best for this, just so you have a workable benchtop surface, especially when you're applying the Bun-Yo-Matic clamp for reduction. And probably the most important pearl would be the quadrant-based approach to joint prep, making it digestible, consistent, reproducible without wide sweeps blind under fluoro. Also, important to check your joint prep with an arthroscope to ensure there's no islands of cartilage left after your joint preparation. At this point, if you need to do a Aiken or oblique Aiken, base wedge Aiken, this would be the time to do so to address that subluxation of the extensor tendon.